Thank you very much for the invitation to be here. It's always a great pleasure to be back in Greece. I remember when I was a student in the 70s, I traveled around all the islands here in Greece, and it's always welcome to be in your country. Thank you. I like to bring you along with the recent insights that we have on heart disease in women and the interaction with gynecology disorders, endocrinology disorders, because medicine is not only about different disciplines, but if we want to move the subject of women's health forward, we have to work together and join the knowledge that we have. That's one of the reasons that I like to go as a cardiologist, to go to gynecology conferences to learn from them what I can bring back into the field of cardiology. Here you see my disclosures. I have no disclosures to mention. If we look at the leading causes of death in women, you can see here on the left side of the panel that cardiovascular disease has a 10 times higher mortality rate compared to breast cancer. And I think the oncology field has done a great job over the past decades to treat breast cancer so very well. But still 1 out of 7 women will have breast cancer in our European countries. But death rates from cardiovascular disease are 10 times higher. And that are heart attacks, heart failure, but also strokes that we can have at young and at older age. And we also know that treating breast cancer with radiotherapy and chemotherapy holds a risk to damage the cardiovascular system. About 15% of women being treated with radiotherapy and chemotherapy for breast cancer will have cardiac damage during treatment, or even 10, 15, and 20 years later. So cardio-oncology is important, but we also have to learn to work together, because the culture of cardiologists is quite different from oncologists. I think oncologists are more friendly, also gynecologists, and cardiologists are not always women-friendly people. I'm sorry about that. So there are many issues. If you look at the evolving field of heart disease, ischemic heart disease, obstructions and non-obstructions in the coronary arteries, we have important differences, high on the left side of the slide, between men and women in the progression of coronary disease. We have differences in risk factors. The impact of the traditional risk factors is different, but we also have female-specific risk factors. Think of hormonal dysfunction, pre-menopause, but also, of course, after menopause, early menopause, early natural or early surgical menopause, which is also different, I'll tell you later. And there are differences in access to care. Poverty is an important fact in women's health. There are more households with single moms with a poorer money situation compared to male households. So there are a lot of issues if we look at healthcare for women that certainly account the cardiovascular field. If you look now how we have thought about coronary disease over the past 45 years, we have looked, and you can see here in red on the left panel, we have looked at obstructions in the coronary arteries. Here you see on the right side the coronary arteries. You see a few big vessels, the left coronary artery, the right coronary artery, but we have thousands, millions of very small vessels. And when we age, elasticity goes away. When our estrogen levels decline, the small vessels stiffen, and we see a more stiffened heart in elderly women compared to elderly men. We have developed bypass surgery, but also coronary interventions with stenting, balloon angioplasty for obstructive coronary disease. But if you look at the female patient, we have more functional coronary disease and diseases of the small coronary vessels than obstructions. And that's an important difference, and it's only since about 10 years that my field of cardiology started to be interested in functional disturbances of the coronary arteries that so many women have between the age of 40 and 70 years. That's the main issue in women at middle age, the most important issue. You can see it here. On the left panel, you can see that middle-aged women, that they have more spasm in their coronary arteries, whereas in male patients in blue, they have more obstructions. And if you look at all the large series in cardiology, millions of patients, 80% of patients that are treated for obstructive coronary disease, a stenosis somewhere in the coronary arteries, 80% of those patients are male. And of course, it happens in women, specifically women above 70 years of age. And if it are younger women, they are often smokers. So what happens more often in women is spasm, functional disturbances of the coronary arteries. And that's one of the reasons also that symptoms between men and women are different at middle age. It's not only because women express their symptoms in a different way, it's also because the underlying disease is also different. Well, what happens, of course, after menopause, here you can see on the left panel a lot of beneficial effects of estrogens on the vessel wall. Estrogens are the most fantastic vasodilators that we have, but as the estrogen levels decline in the direction of menopause, we see a reduced effect on vasodilating effects on the coronary arteries. So it's often when women pass their 50s and they are at higher risk, because not all women have the same risk for cardiovascular disease. That's why it's important to discuss their prior medical history also with a gynecologist and endocrinologist. You can see that after menopause, a lot of systems in the body will change. The thrombotic system is at a higher level, inflammation is at a higher level, there's hormonal dysregulation, and we see a shift in risk factors. Between 50 and 60 years of age, cholesterol levels get higher in women, whereas in men in their 50s, cholesterol levels stay about the same. So because of the decline in estrogen levels, our risk factors get higher at middle age. And that's one of the reasons that at middle age, during menopause transition, we have to investigate whether the woman has a high cardiovascular risk or a low cardiovascular risk. And we can do that quite easily nowadays with the knowledge that we have gained over the past decades. Here you see, for instance, a difference in the shift in blood pressure with aging between men and women. The red line are the women, the blue line are the men, and you can see from the age of 60 years onwards that systolic blood pressure rises more sharply in women. Diastolic blood pressure is not really different, but you can see with aging that both in men and women, diastolic blood pressure gets lower. But specifically, the systolic blood pressure is more important after 55, 60 years and determines, importantly, individual women's risk. And there's now a serious discussion going on whether normal values of blood pressure should be lower in women than in men, because the damage of high blood pressure on the brain, on the heart, on the kidneys is more severe in women. And now a normal threshold of blood pressure is 120/80. So I hope you're not disturbed by that, but half of all women, when they enter their 60s, they have hypertension. When they enter their 70s, it's more than 70%. And in the end, more than 80% of all women will have high blood pressure, hypertension. That's one of the reasons that we see so many strokes in women above 70 years of age. And now it's often said that you don't feel a high blood pressure. If you had a blood pressure for more than 30 years and you are past 80, of course you won't feel it because you're used to it. But if your blood pressure gets higher at the age of middle age, then you will feel all kinds of symptoms. You will feel tired. You can have hot flushes. You can have sleep disturbances, heart rhythm disturbances, all kinds of symptoms that are also very common in menopause transition, that symptoms that are often treated with menopausal hormone therapy. And I'm a big fan of menopausal hormone therapy. I think it's very important in women who have a lot of symptoms, but in many women, it's needed to combine menopausal hormone therapy with therapy for blood pressure, because menopausal hormone therapy is not fit to treat high blood pressure because we have better medication for that. And I've seen many women in my outpatient clinic over the past decades with this kind of symptoms that I treated with antihypertensive medication. And they told me 6 weeks later by telephone, well, my menopausal symptoms are also a lot better. So I feel better. So I'm fine if you want to treat women with hormones, but also measure their blood pressure, measure their cholesterol levels, and if needed, you can combine both kinds of therapy. So don't forget about high blood pressure, because it's the #1 deadly risk factor in women worldwide. Of course, I have blood pressure since many years. So a lot of things change during menopause transition. With the decline in estrogens, we see more chronic diseases. And if you look at old age in patients above 70 years, you will see more women with a combination of all kinds of chronic diseases, more than what we see in men. And all those chronic diseases, often inflammatory diseases, are also important to determine whether a woman is a high-risk woman or a low-risk woman. And if you look at fat deposition, when women pass through menopause, the abdominal fat has a high pro-inflammatory state. So it's important, of course, to maintain a healthy lifestyle, to move as much as you can, to keep a healthy diet, etc. I'm not going to talk about that because I think you all know what we need to do. So when we enter menopause, but also before, in patients with premature ovarian function and PCOS, and perhaps also endometriosis, we see that there's more insulin resistance, We see with the shift into menopause, more inflammation, and it's all an important trigger also for the rise in blood pressure, hypertension, the most deadly risk factor that we have in women. What we also see is that the decline in estrogen leads to heart failure with a stiffened heart. We call it heart failure with a preserved ejection fraction. That's a difficult name for a stiffened heart. And we see a lot of those hearts in women above 70, women who have problems with walking, who are often out of breath, and it starts 20 years earlier when they pass menopause. So that's one of the reasons that we have to look for blood pressure, but also diabetes, lifestyle factors, obesity in women at middle age to prevent the stiffening of the heart, because it's not treatable and not reversible. And once you have a thickened heart, you will keep symptoms for the rest of your life. So have a look at those factors at an earlier stage and not above 70 when it's in fact too late. So on the right side of the slide, we have a lot of diagnoses in cardiology with important female to male differences. We have the traditional risk factors, we have the lifestyle factors with an important impact differences among men and women. I'm not going to talk about that in detail, but in the middle we have important female-specific risk factors, like preeclampsia, HELP syndrome. We know that women who had a preeclampsia, that they have a twofold higher risk to have a cardiovascular problem at young age compared to women who had normal blood pressure in pregnancy. We also know that, of course, gestational diabetes holds a high risk to develop diabetes and later on cardiovascular disease. The use of oral contraceptives has no higher risk for a heart attack or heart failure. We know only that in the first couple of months when you use oral contraceptives, there may be a slight elevated risk for thrombosis, but there's no contraindication to use oral contraceptives in healthy women before menopause. So there are many issues different among men and women. Age at menopause is, of course, very important. And I'll show you one slide that an early natural menopause is associated with a higher cardiovascular risk, but an early surgical menopause around the age of 40 because of a BRCA mutation carrier doesn't seem to hold a higher cardiovascular risk. And I'll show you one of the studies that we have done to demonstrate that. Another example, it's now quite under the attendance of women's health at the moment in Europe, endometriosis. It may take several decades before the diagnosis is set, about 10% of women. And there are many signal pathways that also lead to a higher cardiovascular risk. And we're doing now some research with the Department of Gynecology at the Radboud University in Nijmegen to investigate women with the diagnosis of endometriosis for their individual cardiovascular risk. It's a chronic inflammatory disease, and we know that most of the chronic inflammatory diseases are also related to a higher cardiovascular risk. So that may be also important for other workers in women's health. Well, I told you already, severe hypertension in pregnancy, preeclampsia, holds a higher risk for future cardiovascular disease at young age. We have shown that about 40% of women after a preeclampsia that they already have hypertension at the age of 40. which is now coming into our guidelines of the cardiovascular community. It took a while, but now it's in our guidelines that if a woman had severe hypertension in pregnancy, that they need to be followed afterwards for their risk for hypertension, and also when they go into menopause for their risk for dyslipidemia and other cardiovascular risk factors. Here you can see also that hypertensive cardiovascular hypertension disorders of pregnancy, they have a higher risk for coronary artery disease, but also heart failure that is often connected, of course, to hypertension, but also valvular heart disease like aortic stenosis. We see more calcification in the valves in women after hypertensive disorders of pregnancy, but also more leakage, regurgitation of the mitral valve. So there are lots of cardiovascular syndromes, diseases connected to problems during pregnancy, and that's another reason to work closely together. But also family history is important. This is a bit difficult slide, but it comes from a large Danish registry in more than 1 million parents. And if you look at those parents and their cardiovascular risk, if those parents had more daughters and more daughters having had miscarriages, their risk of the parents is higher. So it's also very important in all women at middle age to ask for the parents' history of cardiovascular disease. And we know that having had more than 2 consecutive miscarriages, that also holds a higher risk for cardiovascular disease. So family history is very important. And we also know that if there is hypertension in your family, your mother and also your father, that you can be sure that you will develop hypertension, certainly as a woman. So we need to embrace the life course of our female patients to discriminate between high and low risk women at middle age. We have to ask for the family history, for genetic traits, but also we have to ask about migraines. Women with migraines since their teens, they also have a higher risk to develop coronary artery disease at middle age and other cardiovascular problems with aging. The gynecology and obstetric history is important, but also at older age, socioeconomic factors, poverty, loneliness are of course also very important for individual cardiovascular risk. So if you talk about sex differences, we talk about the pure biological differences among men and women, but more and more gender issues are also important, related to how we live in society, our position. So I think good health for women is also talking about positions of women. And I used to call myself a cardio-feminist. And if you look it up on Google, you will find one name, and that's my name. So it hasn't been embraced as a topic, so I keep it for my own. Well, of course, menopausal hormone therapy can be very helpful for many, many women who need it. And of course, it's best to start as early as possible and not to take it until you're 95. And those who can do it best are the gynecologists, the endocrinologists like you are. But we have to bear in mind that next to the positive effects, there are also negative effects. Specifically in women having had problems with the cardiovascular system, but also women with the thrombotic system, we have to take care. And with all the kind of different products that you have developed over the past decades, like gels, transdermal therapy, low dosages, even the use of transdermal therapy can be very safe in women after a myocardial infarction. It's not forbidden. And I know now in the NICE guidelines of the in the UK, that it's also allowed to continue hormonal therapy even after a cardiovascular event. I think I'm over time, am I? Oh, I'm sorry. Well, I'll close my talk. Important, if you are uncertain about individual women's risk, you can do a coronary artery calcium score. That's easily investigation you can do at the radiology department in one of the hospitals. You can see here in green how calcium enters our vascular system during lifetime in men. In blue, it's in women. So if we age, we will have wrinkles on the outside, but also on the inside. So the development of calcium is normal. But we have shown that if you look at calcium depositions in women after preeclampsia, you can already see calcium in at least 1/3 of those patients at the age of 50, which is quite early. So if you are hesitant, if it's a high-risk women, if you want to prescribe hormones, you can decide to do a calcium score. And if it's a high-risk woman, perhaps you can choose another kind of therapy. So we also know, this is a very recent publication, that women with a history of preeclampsia, they have more plaques in their vessels, though that has been investigated recently. They also have a bigger volume of their plaques compared to women with normal blood pressure in their pregnancies. And this is a bit a difficult slide, is of a publication that we recently did. We also looked at the calcium scores in women after preventive bilateral ovariectomy in a series of women before menopause, but also after menopause. We compared those women with a reference group, and we showed that in women with surgical early menopause because of BRCA mutation carriers, that they did not have more calcium in their coronary arteries compared to a control group. And we know that in women with an early natural menopause, they have an earlier sclerosis of their ovaries, that they do have a higher risk. So, so the doses and types of menopausal hormone therapy are important. If you have any doubt about safety, you can consider to do a coronary calcium score. It's not expensive, it's a very validated tool to discriminate between high and low risk women. And if you want to know more, we wrote a book with many experts in the field of women's health that came out in 2024, and another book for the lay people a couple of years earlier. I'm sorry I'm over time. Oh, sorry. But thank you for this lovely invitation to be here.